Okay, I think we're live, and I have a new issue of the Journal of Clinical Oncology, which is the official journal of the American Society of Clinical Oncology. It's the year 2023, volume 41, issue 2. And one thing noteworthy is that the Journal of Clinical Oncology now exists 40 years, which is a milestone, and interesting to note that it's only 40 years. The field of oncology, or actually the field of medicine, is really not that old. And if you think about the fact that our most official, highly validated and respected journal is only 40 years old, so that's when they just started doing all the clinical trials for treatments to cure cancer, and before that cancer was not curable. It's astonishing how far we've come in 40, 50 years. So the cat is here, Melky. Bertha is here. I wish you all a very happy, healthy, joyful 2023. Bertha, I hope you had a good travels. I don't know if you're still on your travel or if you're back in the Pittsburgh area. I hope you're well and safe. And as I usually do, I'll just go and read you some of the highlights of this particular issue. I try to limit it to 10 minutes, and then I'll see if there's any questions that come up. This issue is very thick. The issue that came out over the holidays was very thin and didn't really have anything relevant. This issue is very thick and has lots of relevant articles, so depending on how things go, I'll put a timer. We may split it up in 2 sessions, but let's see. So, lots of commercials, advertisements about new medications that pay for the cost of printing this journal, but also very educational for us to understand which medications are new. The whole drug insert is printed in this journal, as you can see, which is very helpful for us to have it as a reference, a CME, and to continue to re-expose yourself so you remember better. So, it's an interesting question. I just was thinking about this. If patient advocates can become a member of ASCO, I think you pretty much can, but I would have to sort it out. It's not listed here in the general instructions. So here we go, the first abstract, I think, unless I missed it. Yeah, first abstract. The first abstract is basically grand rounds, a complicated case that different experts comment on in terms of how to manage a complicated case of rectal cancer. And that case and grand round topic have been selected based on another article that's a little deeper into this issue. Let me find it for you, because I think it's very good news. Here we go. It's an abstract that you can fully access online. When you go to the link associated with this live, you can go to the listing this particular abstract that's entitled Neoadjuvant Chemotherapy, Excision and Observation for Early Rectal Cancer. And the purpose was to look at the ability to do organ-sparing treatment for rectal cancer, early stage 1 and stage 2A, to avoid functional disturbances such as dysfunction of your sphincter, and so diarrhea, or a permanent need for an ostomy. And so what they did is something that we're doing in other tumor types already, and a big example of that is breast cancer, where we often try to, for the appropriate case, try to administer systemic therapy with the hopes that the tumor in the breast, for those who have early stage breast disease, can shrink down so that the local regional treatment with radiation or surgery can be less, and so there's a shorter recovery time, and there is less long-term consequences in terms of having asymmetry, in terms of having shoulder dysfunction, and so forth. And in breast cancer, there has not been found to be a negative consequence of this approach in terms of survival. And now they're starting to look into doing this for other tumor types, and one of them is rectal cancer. And so these are the results. This abstract reflects the results of a whole manuscript, which I won't delve into. You probably won't be able to read the whole manuscript, but you can read all the abstracts for free online in the link I put in there. And these are the results of a phase 2 trial that included 58 patients. And to cut to the chase, 3 months of induction chemotherapy, or neoadjuvant chemotherapy, meaning systemic therapy before surgery gets done, may successfully downstage a significant proportion of patients with early stage rectal cancer, allowing a well-tolerated organ-preserving surgery. And so this is not appropriate for all, and so you really have to go to somebody who's an expert in this particular type of cancer and deals with this in a high volume, to be evaluated and see if you qualify for the same approaches that I just outlined. Maybe first systemic therapy to shrink down a tumor size, and then have less morbidity afterwards, and hopefully still the same survival. They reported here that the one, let me see, it's always complicated to read this because every paper seems to report it slightly differently. They're working on making this more uniform, but until then. So the 1 year and 2 year local regional relapse-free survival was respectively 98% and 90%. And there were no distant recurrences or deaths. So this is a phase 2 study, and what it means is that they will go on to a phase 3 study to really look at whether this particular approach is making a difference. A phase 2 study tries to focus more on feasibility and tolerability, and as you move forwards from phase 1 to phase 2 and eventually phase 3, they look more at how effective is this really. So I think we just have to wait and see for phase 3 study results and a larger amount of patients enrolled in a study to see if it's really as promising as it looks like and does not result in inferior cancer-related survival. But in general, that's the trend with cancer treatments, that we try to aim that maybe less is more in terms of same survival but less morbidity, because many of us are often paying the price when treatment is done from a treatment that really causes some long-term damage. I see Carol is watching. I see Inga is watching. Hi you guys. So the 10 minutes are almost done, and I only got through a few of the articles that I wanted to talk about. So let's see if we can maybe add one more article, and then we'll split it up for another session later in the week. We talked about Guerin rounds for rectal cancer and the new finding of neoadjuvant therapy for rectal cancer. Another topic, let's see if there is a short one. Okay, this is also an interesting one that might be relevant to some of you who are watching. I see Becky is watching. Hi, Inge. So this is a study that aims at bladder cancer that is invasive but not invading the muscle, and how to best manage these individuals. For the most part, we're often treating these individuals with very close surveillance, with a bladder wash, with a topical agent that stimulates the inflammation and immune response to the bladder, with the hope that that will help reduce future recurrences of these superficial bladder lesions that, once they happen, are at a high risk of reoccurring. And so these individuals are getting these every 3 months, sometimes even, if not more or less often, depending on what your circumstances are. But you would need to have surveillance, prophylactic bladder washes with these chemo agents, and then immuno agents, and then remove any lesions that are not supposed to be there. That's sort of the current approach, but this particular paper was presenting the data of a randomized controlled trial that was performed in Denmark with 120 patients. And what they, I think, tried to do is that they tried to compare the standard, which I just outlined, with sorry, Cookie is walking around here, I'm not sure why, with the intervention that they proposed is administering this chemo immunotherapy agent 3 times a week for 2 weeks, very intensively upfront. And what they found in this particular study is that the short-term intensive approach is an effective treatment strategy for recurrent non-muscle invasive bladder cancer. And it reduced the number of required procedures without compromising the long-term cancer safety. That's what they concluded here. And so I think all of that is very, very promising, although we have to have other studies that are able to reproduce that, and in particular in the American system. And having said that, the 10 minutes are over. My animals are here. I'm snuggling a little bit. I'm going to wind down and do this perhaps again later in the week if all of you enjoy listening to this, if you find it helpful. I'm trying to address topics across the board so it's relevant to survivors of any tumor type. I see Stasha's watching. Inga loves my windmill pictures. Thank you. It was very difficult to line them up. I do not recommend getting something like this. Again, at least I'm not going to get something like this again. But it looks very nice, and our whole apartment is hanging full of windmill pictures to make me feel like I'm home a little bit. Maybe I should, we're trying to get some pictures from other countries as well. Becky, Carol, Inga, Bertha. Is there anything you would like me to answer before I hang up today? So Inga, one thing I would like to mention is for some reason, everybody who's watching right now, I can bring them on the video, but I can't bring you, Inga. You don't have the button for me to bring you on, which is really weird. Oh, wait a minute. Yeah, I just sent you the button. Let's see if it works. And then we're going to hang up. Thank you, Bertha. You're Inge. I can send you more windmill pics because I'm weird. No, you're Dutch. You're not weird. You're Dutch. We both are Dutch. Okay, well, I wish all of you a good night. I will upload this for other people to watch who aren't able to join live, and then I'll hope to catch all of you soon again. Thank you. Bye.